Now, these are the few common indications of a pelvic fixation when we expect a very high significant biomechanical stress at the lumbosacral junction, when you have long fusions to the sacrum. By long fusion, definition is above anything more than 4 levels. So you go above L2. When you have an oblique takeoff at L5S1, like in a lumbosacral scoli or a lumbosacral listhesis, when you have a prior laminectomy, wherein you're expecting instability at the lumbosacral junction or in severe osteoporosis, this were some of the indications where you would want to take in the pelvis. Now, there are 3 primary concepts in lumbosacral fixation. One is the lumbosacral pivot point, sorry for the typo, as described by Macron, and then zones of sacropelvic fixation, as well as the S1 screw triangulation, out of which we all are very familiar with the S1 screw triangulation, wherein we try to put a bicortical S1 screw. Will not dwell much into it. So the lumbosacral pivot point is as described by the McCord. It says that the lumbosacral junction, the pivot point is located at the posterior part of the L5S1 disc. So if you look at the actual image, more anterior or more longer is your screw, as more stable is your lumbosacral concept, lumbosacral construct. So with that, if you put bicortical S1 screws, so this is your pivot point, and these are just only as long as this. If you have a ALS screws, they are shorter than the bicortical or tricortical S1 screws. Whereas if you put a iliac screw or a S2AI or a S2AI screw, using the tips of them, they are much far ahead of the lumbosacral pivot point, and that leads them to be much more stronger constructs. The second concept is about the zones of O'Brien. So O'Brien has described these 3 zones in the lumbosacral region, which are useful for fixation, in which zone 1 is our standard bicortical or tricortical S1 screw and the ALS screw. This is zone 1, which extends in the S1 body. Zone 2 is from the inferior margin of the sacrum to the coccyx. So this is zone 2, and zone 2 is the iliac bone. So structurally, as we go from zone 1 to zone 3, the fixation becomes more stronger. That is the idea behind these zones. This is another concept which we use in lumbopelvic fixations. So if you look at the evolution of this from the early 60s, wherein the Harrington hooks were used to fix the pelvis, it has moved over in the last 35 years. And in the mid 2005, the S2AI came to practice. And by far, the iliac screw or the S2 LR iliac screw are the popular techniques or most biomechanically sound techniques of pelvic fixation today. So these are the 4 common methods: the tricortical S1 screw, the iliac screw via a iliac connector, or the so-called anatomic iliac screw. We'll see into it. Third is the Amrita technique of iliac fixation. And fourth is the S2 LR iliac fixation. We'll go briefly into all of these. Now, I'm not dwelling much time on the tricortical ALS screw because it's standard tricortical screw. So we'll go to the iliac screw. So this is the conventional iliac screw entry, wherein you expose the PSIS, you take a notch in the PSIS, and you insert your screw along the table of the ilium. So that is the conventional iliac screw. But remember, you have your S1 screw at this point, and this is your conventional iliac screw entry. So you need to have a connector to connect your lumbar pedicle screw to your iliac screw. This was modified, and there was this anatomic iliac entry described, wherein no notch was made and an entry medial to the PSIS was used, and this could connect the rod right away as the way come from the lumbar spine. This looks very easy on the model, but in real life, we know that it has its own nuances. Now, this is a bone model picture to demonstrate both these fixation. The one on the left is where it's a traditional screw wherein you take a notch in the ilium and you have a screw here and you would use a connector. And this is where you have used a anatomic origin where you don't have to take out the notch, and this helps to sink the screw. Now, what are the disadvantages of using iliac screws? You need a connector, so that gets in some modularity. So it decreases your strength of fixation, and at times it might not let you take good grafts because of your, if you're taking massive grafts from the ilium, your screw might not really hold well. So this is one of our patients wherein we have used both. So we classically use this so-called Mercedes-Benz approach whenever we use a pelvic fixation, because we try and put all these screws freehand without using imaging, navigation, or even CHAM only for final confirmation. So we feel the iliac crest, iliac table, and that helps us put the screw without imaging. So in this particular patient, I have used this is the conventional technique wherein I got a notch and put in the screw. On the opposite side, I used the anatomic the anatomic insertion. So in this, I did not use a connector. In this side, I used the connector. So this is an example of iliac fixation where on the left side, I use the conventional method. On the right side, I use the anatomic method. So this was a lumbar degens coli, which was corrected. Now, next is the Amrita technique. So why it was devised? Because it needed no iliac connector, so no modularity. It does not need any special gadgets for imaging, and it is biomechanically as strong as S2AI screws. Today, we use it only when we do sacral resections, wherein we don't have any sacrum to put an S2AI screw, or if not, my choice of pelvic fixation is S2AI screws. So this is the Mercedes-Benz approach which we use in all our pelvic fixations. So this is just a bone model demo. We take in a notch like we do for our normal pelvic screw. And then this is how the rod is bent to do the Amrita technique. So you do a freehand all insertion into your iliac screw into the one which goes superior to the notch, and the other one it goes along your iliac superiorly. So these are two screws, and this is the way they are inserted. They have a conventional 7 millimeter or 6.5 millimeter or 7.5 millimeter pedicle screws. This is how they are used. So this is the way the rod. So the rod has only one bend, and this is how the rod is inserted. And this is a intra view of how the screws are used. So today we reserve it for doing such a sacral resections wherein we don't have any ilium or anything remaining after we do the tumor resection. And this is how it is used, this salvage this situation. Now, this S2AI or the SAI as it is called is today by and far the most popular technique of sacro or a lumbosacral fixation. Multiple advantages. You don't need any connector or anything to connect your main construct to the S2AI screw. They all line up very well. You can safely insert your S1 screw. So wherein you are doing a lumbosacral pathology like a discitis or something where you have to have at least 2 level holes distal to your fixation, you can safely put in a sacral screw, tricortical, as well as use S2AI. So that gives you a very strong construct into the pelvis. And this is how an actual CT scan would look like. So it starts in the sacrum, goes through the SI joint, and goes into the ilium. That is the S2AI screws described by Hardcastle. So this is how you can use a freehand insertion. We by far use the freehand insertion of putting S2AI screws. That is why we use the Mercedes-Benz approach, because I can feel this part of my ilium with my finger when I start my insertion with my awl. This is the entry point of insertion. It's midway between the S1 and S2 foramina. You'll use the lateral border of the of the foramina. I use the long 2.5 millimeter drill from the pelvic fixation set. And trajectory, different books have got different guidelines. By far, my choice is to feel the lateral border of the ilium. That gives me my lateral angulation, and then I feel the anterior inferior spine. I cannot feel it in a draped patient, so I feel the tip of trochanter. So every patient where I plan for a pelvic fixation, if the trochanter will be very well felt. We drape it wide so that we can feel the trochanter, tip of the trochanter, and that aligns up with the anterior inferior iliac spine. And you have to probe throughout and confirm the bony endpoint with your probe. This is how we do it. This is the strongest bridge of bone which we classically use for this fixation. So I use the finger and feel throughout the surgery, and that is how I kind of go ahead and place my screw. So this is the strongest part of bone which we exploit for our screw fixation. So typically it will take we use a 7.5 or an 8 millimeter screw around 7.8 millimeter thick screw, around 80 to 90 millimeter length is what is used. So some companies have those dual threaded large screws which are really, really strong for adult deformities. This is how we use them. So you can use the so-called obturator teardrop view when you start off. This is okay because we seldom use it today because it takes a lot of your Shyam tech has to be extremely an expert to get these obturator view very well. So the better thing, if you can learn the freehand technique wherein you feel the outer part of the ilium and then feel the AIIS, and it helps you. And once you start your all, you can use fluoroscopy to guide you well. So two axial CT scans from the book to show you the difference between iliac screw and S2AI screw. You can see the obliquity and the angulation of doing this. So a couple of two cases to share. This is my oldest patient with a S2I fixation, a 70-year-old male retired physician with Dejan scoli and back and leg pain, significant disability, wanted surgery at 70. So this we went ahead, did an ALIF, and then did ahead and did a fixation. This is how it is. And this is my youngest patient of a S2I screw, who was a 6-year-old girl with a low dysplastic listhesis, developed a cauda equina. So we had to go in. It was L5S1 cartilaginous bone. We had to go in and do a TLIF kind of reduction and we use the longest pediatric screw available that day, which was 50. So it was really short for her still. They would not take, because if I used a 6.5 or 7 millimeter screw, the rod was 4.8. It will not take the rod. So I had to use the longest one in the pediatric instrumentation set. This is my youngest S2AI. So if ever you want to get scary of this particular screw, this you can Google this article by Jens Chapman and team, which tells about the neurovascular relationship of the S2AI screw placement. If you read the amount of complications which can happen after this article, you will never ever attempt it. So this is just a scare factor. So to conclude in one picture, these are the variable screw entry points when we plan a lumbo-pelvic fixation. The first one would be our conventional S1 tricortical screw. This would be our conventional iliac screw. The blue one would be our anatomic iliac screw, and the red one would be our S2AI screws. These are the 4 options you have, which can be used in combination when you want to get about a very strong lumbosacral fixation. The last picture. So to conclude, these are the different zones or different types of sacropelvic fixation with respect to the zones. So we saw that as we go from zone 1 to zone 3, we have stronger and stronger fixations, which are biomechanically more stable. Zone 1, we have the tricortical sacral pedicle screw. Zone 2, we have the S2 screws. And zone 3, we have the S2I and the iliac screws. So by far, the zone 3 fixation and zone 1 fixation are more popular. the transiliac rod is no more popular for lumbosacral fixations. Thank you for your patient listening. Any questions, please?